It's really a pleasure to get together with you, and I hope that today's presentation proves to be a benefit of you, because it's in a very, very significant topic, one that is becoming ever more important as time goes by. And that's the idea of, when do we consider doing, in women with diminished ovarian reserve and older women, when do we move across from IVF using own eggs, conventional IVF that is, to egg donation, and what is the alternative? How does the concept of embryo banking fit into this equation? Let me see if I can make this work. How do I move the slides along?
You click on there, you can get the...
Okay. Now, you can submit all your questions into the chat box that you'll find next to the video window, and you can put that in at any time. I'll be answering questions as I receive them later on at the end of the presentation. I'm going to try to keep this presentation reasonably brief to leave lots of time for you to ask questions. We have a very busy webinar. There are a lot of people on this webinar, and I'll try to answer all the questions that come to me. Another thing that's important to tell you is that you can get more information on the issues we're discussing here by visiting my blog, primarily the IVFauthority.com. All you do is go to the home page, type in egg donation or embryo banking or diminished ovarian reserve. There are over 500 articles I've written there, and you'll be able to find your way to any topic that we discuss here by going to the articles on that blog. Also, you can go to the discussion board at haveababy.com. I urge you, when you get there, to go to haveababy.com and then to the Las Vegas discussion board, because that's the one I frequent. And if you post questions there, I can answer those as well. And on my blog, there's an opportunity when you get to the home page to also post any questions on the home page or make any comments, and I will come back and answer those, as I usually do. Another important thing is that, take a note right at the beginning of this 800 number, 800-780-7437. Please, I'll be mentioning it as we go through the presentation. All you have to do is call that number, ask for Tina, and she can set you up for a Skype consultation with me. I'll be delighted. For those people that live in the Las Vegas area, call her and set up a consultation to come in and see me, and we can discuss your case in detail. Just bring your records along with you. We're very busy, so I urge you, if you want to get in, it's going to be first come, first serve. Don't hesitate to call that number again. It's 800-780-7437, or you can also schedule a consultation directly from our website by going to haveababy.com. So we're going to be talking today about the whole idea of ovarian reserve, age, and how this impacts on whether or not you go to embryo banking or do egg donation. But central to the whole concept is an understanding of what the biological clock is all about. The biological clock, which is generally referred to as those changes that occur that make it more difficult for the woman to conceive as she gets older or closer to the menopause. Now, you must know this, and I'm sure you're all aware of the fact that menopause in the United States occurs in American women, or in women in first world countries, somewhere between the age of 40 and 55. That's when you stop menstruating, when you stop ovulating and producing eggs altogether. But that is by no means the total, or those are only the extremes. Some women will go into menopause in their 30s or even in their 20s, and some women never go into regular ovulation. They're in ovarian failure all the way from birth. So when we refer to the biological clock, we're looking at, firstly, when the menopause occurs and how age and ovarian reserve are impacted by it. So let's first talk about the effect of age on the fertility of women. There's no doubt that as women get older, their fertility potential decreases. Let me just switch this off. Their fertility potential decreases quite dramatically, such that when they get into their mid-40s, the chance of a pregnancy per month, or the chance of having a successful pregnancy per month of trying, drops to about 2%, from about 50% when the woman's in her early 30s and late 20s. So it's important to recognize why this happens. The effect of age on fertility is primarily through the effect on the woman's eggs. The sperm plays much less of a role. As a woman gets older, egg quality declines. Her eggs have been in her ovaries ever since she was in her mother's uterus. And through wear and tear on the eggs in her ovaries, as she gets older, there's a decline in fertility that is most profound after the mid-30s and really starts to decrease precipitously thereupon. And it's mainly because the eggs, as a woman gets older, the ones that are ovulated or extracted at IVF, are more likely to be chromosomally abnormal with advancing age. At the age of 30 or even up to 32, 33, 1 out of every 2 eggs that a woman produces is chromosomally normal, which means it has all of the chromosomes necessary. When she gets to 35, the percentage of normal eggs is probably down to about 1 in 4. 1 in 4 will be normal. When she gets to 40, only about 1 in 6 is normal. And when she gets to 45, only about 1 in 20 is normal. So all the remaining eggs, 19 out of 20 when you're 45, and 1 in 2 when you're in your early 30s, will be normal, will be abnormal. Only 1 in 20 will be normal at 45, and 1 in 2 at 30. That shows the remarkable decline in fertility that is primarily related to the quality of the woman's eggs as it pertains to the chromosomal integrity of those eggs. There's nothing you or I or anyone can do to change that equation. There are no medications you can take. There are no treatment modalities that reduce this equation. Another important thing about eggs is that 4 months before they're used in a given cycle, they go through a recruitment journey where the eggs prepare themselves for the process of the cycle that is to come. And we know very little about this recruitment journey. It's really in the cycle of stimulation that those eggs that appear at the starting gates of the cycle are then used, and one of those, or sometimes two, depending upon your family history and your genetics, will ovulate and result in a single or rarely a twin or more pregnancy. So it's extremely important to know that we can do nothing. We don't shuffle the deck. We don't deal the hand. All we can do is play the hand that is dealt by nature, by God, by whatever you want, genetics or whatever you want to call it. Basically, the eggs that appear to be used at the starting gates of a cycle have been in the process of preparing for that event 4 months in advance. And we have to deal with the ones we've got. When it comes to doing IVF or treating fertility, you need to understand that a good practitioner, a good doctor, a good player, a good team will win a winning hand, one where there are some normal eggs in the batch, ones that would end up being chromosomally normal when the cycle begins. Whereas both a good player and a bad player will lose the poor hand. The poor player will lose the good hand as well. So IVF, the success with IVF has much to do with the quality of the eggs that we have to work with when the cycle begins, and secondly, the way we stimulate the woman, the way we select the protocol of stimulation to nurture those eggs during their developmental phase, because otherwise, especially in older women and women where the ovarian reserve declines, in such women, we will end up having a much greater vulnerability of the eggs. and a greater likelihood that even a normal egg that starts off normal will end up being chromosomally abnormal or aneuploid by the time it ovulates or is extracted. And again, we can do nothing about age, but we sure as heck can do a lot to improve the environment in the ovary that the egg is exposed to as it develops, and that plays a very critical role in IVF. And if you forget everything I tell you to this evening, remember one thing, and that is there is nothing more important in IVF than the way in which you stimulate the woman when she's preparing for egg retrieval. You've got to use a strategic, individualized approach to stimulation. The effect of using a one-size-fits-all or recipe approach to stimulation is you can get away with it in younger women who've got normal ovarian reserve, but you won't get away with it in older women and women who've got diminishing ovarian reserve, where you've got to be very individualized and strategic, and we'll talk more about that later. Here you can see what happens as a consequence of age when it comes to the woman's fertility. Is another picture which shows you the fertility rate per 1,000 married women who are fertile. You see it declining all the way down to 45. And look here, the miscarriage rate also increases. It increases dramatically, such that at age 45, the chance of miscarriage is about 80%. At age 40, the miscarriage rate is about 44%. Whereas the normal miscarriage rate in a woman that is in her 20s or early 30s is around 15% to 20%. There's nothing you can do about it, because the same factors that make the egg more likely to be abnormal because of age, resulting in a failed IVF because of chromosomal abnormalities in the egg as the woman gets older, those very same factors result in abnormalities of the eggs, which, if they were to begin attaching, would be less likely to stick because they're abnormal. And no question, 80% of miscarriages that do occur because of chromosomal abnormalities in the embryo. And this is definitely linked to the woman's age. So what are the options when we deal with issues of egg quality? I think the first thing, let's go back again. I want to just mention something else here. The other thing is you need to understand that the only way to determine how close a woman is to menopause, because remember, there are two things I started off by saying that determine the biological clock. The one is the age of the woman, and the second is her ovarian reserve. And ovarian reserve refers to the number of eggs still left in the ovaries. As a woman uses more and more of her eggs up, she gets closer to menopause, her ovarian reserve declines. And we can measure that reserve in several ways. One, we can measure her basal or her FSH on the 2nd to the 4th day of her period. That will tell us if the higher it goes, when it starts going over 9, then that is an indication that the total collection of eggs remaining in the ovarian repositories is declining, and she's getting closer to the menopause. At a time, therefore, where fewer eggs will be extracted, and you'll need a higher dosage of stimulation to be able to get those eggs, those follicles, to develop and yield their eggs. So as a woman gets closer to the menopause, regardless of her age, usually, as I say, that is between 40 and 45 and 55, as she gets within a few years of that menopause, her ovarian reserve drops below a certain threshold, and it's suggested by a rising FSH. And more recently, a better test than measuring FSH, one that can be done any time of the cycle, is measuring anti-Mullerian hormone. Anti-Mullerian hormone. And this hormone, in American units, would be anything above 2 nanograms per milliliter being normal. 1 to 2 being reduction in reserve, 0.5 to 1 being serious reduction in reserve, and if her AMH is under 0.5, it's very critical. The reduction in ovarian reserve is very critical when the AMH is under 0.5 nanograms per milliliter. And then there is the issue of the inhibin B. It's another substance we can measure. It's produced by the follicles, and when the inhibin B is above 45 nanograms per milliliter, it suggests great ovarian reserve. If it is under 30, it's very low ovarian reserve. If it's between 30 and 45, it's intermediate. But this is no longer being used as widely. The most vital one of all today seems to be the AMH, and that in conjunction with an FSH in association with an estradiol that's normal will give you a good indication of how many eggs are left in the ovaries, therefore how many you're likely to get with a given stimulation protocol, and it'll help you design the protocol that's best for the woman. There's one other parameter, and that is the antral follicle count. These are the little follicles that appear in the ovary just before the cycle begins. They measure a few millimeters in size. By counting those, you can get an idea of what the maximum potential for egg formation in the upcoming cycle will be. It's not absolutely accurate, but it's a general indicator. Again, the most reliable method of testing ovarian reserve is to measure the AMH at any time and the FSH level between day 2 and day 4 of the period. So what then, if a woman's got diminished ovarian reserve, it means there are going to be fewer eggs available. If, and on top of that, she's getting older, it's going to mean that the eggs, the fewer that are available, are going to be of a poorer quality, are more likely to be chromosomally abnormal. And that creates even a bigger dilemma. If we have a woman with diminished ovarian reserve in her 30s, in her mid-30s or early 30s, and you stimulate her correctly so that you avoid corrupting egg development and creating more abnormal eggs than need be, such a woman's eggs should be able to yield the same percentage of normal embryos once fertilized with sperm as would be the case if she did not have diminished ovarian reserve. So age is the major determinant, influenced by the way in which we stimulate the woman. Again, I can't overemphasize how important it is, especially in older women and in women with diminished ovarian reserve, to be very strategic in the way you stimulate the woman's follicle growth. And then so using the woman's own eggs is the option number one. The traditional way of doing IVF would be to say, okay, let's keep doing IVF over and over again, and so that if we keep doing it enough times, the woman will hopefully get pregnant. Granted, the chance of pregnancy will decline with age. As I'll show you in a later slide, the chance of a woman of 40 having a baby through conventional IVF where 2 or 3 embryos, preferably no more than 2, are put in the uterus is going to be no more than about 20 to 25% per cycle, and the chance of a miscarriage 40%. So the yield is going to be something like about a 17 or 18% baby rate per cycle. At 30, where 50% of the eggs are normal, here the chance of a baby being born is going to be, if you put in 2 embryos in the uterus, about 40 to 50%. Much higher because the eggs are more likely to be normal, even if there were less of them, they're much more likely to be normal. So the focus has to be on generating chromosomally normal, quote, competent embryos, which will come from competent eggs, to propagate embryos that will be able to make a baby. And of course, at the age of 30, the miscarriage is going to be no greater than 15%. So it becomes very important to realize that as women get older, the results, the success rate with IVF will dramatically decline. At the age of 35, after 35, it starts going down already. After 40, it drops precipitously. And in a woman of 45, you put back 2 embryos, you probably have less than a 5% chance of a pregnancy, of a viable pregnancy that goes to a baby being born, because the baby rate, there's a very low viability rate, the abnormality rate, the chromosomal aneuploidy or abnormality of the eggs and embryos will be far greater as the woman gets older. and the miscarriage rate at 45 is about 80%. So there's the balance. We've got to be able to get good embryos into a receptive uterus. And the good embryos are going to be linked to the age of the woman, and her ovarian reserve will determine how many there are. Obviously, the fewer eggs a woman produces, the less the likelihood is that she's going to have a healthy one amongst them as she gets older, because the percentage of normal ones go down, and you have to have a normal embryo to make a viable pregnancy and to avoid miscarriage. The second option that you have when you use your own eggs is called embryo banking. We're going to talk about that later on as well. It is a revolutionary approach, and you'll see how it works later. What we try to do here is, by accumulating numerous embryos that reach the blastocyst stage over several cycles, and testing those embryos in advance to see which ones are normal chromosomally, we then are selectively improving the efficiency of the process, because the normal embryo that you end up with will be the one that's almost as likely to make a baby as if the woman was younger, because you've culled out, you've excluded those embryos that were abnormal. And again, the abnormality of the embryo is in large part a function of the egg's normality chromosomally. We'll be talking about how we can improve the chances of a baby by selectively putting back a chromosomally normal embryo, and reduce the miscarriage rate almost tenfold at the same time, and also in the process reduce dramatically the risk of chromosomal birth defects such as Down syndrome. But right at the outset, I'm going to warn you about this. If you do embryo banking and it takes 3 cycles to make enough embryos for testing to reach the 1 or 2 normal ones, you need to bear in mind that the process of testing embryos does not make better embryos. It simply identifies those that are good and gives you a better chance using those that you'll have a baby. So it is an efficiency process. If you were to put back embryos 1 at a time or 2 at a time through conventional IVF without doing the testing and without even banking the embryos, the cumulative chance of having a baby would be the same. But the risk is that you'll put back abnormal embryos, it'll take longer to get pregnant, you'll be wasting repeated embryo transfers. Financially, that's costly. Emotionally, it's even more costly. And at the same time, you'll not be reducing the risk of miscarriages, which, as I said, at the age of 45 is 80%, at the age of 40 is 40%, at the age of 30 is only 15%. So when you do embryo banking and you selectively bank only those embryos that you find to be chromosomally genetically normal, and then put back 1 at a time or 2 at a time, you'll get a pregnancy rate which can be 3 or 4 times higher at the age of 40 than it would ordinarily be. And at 45, where the overall chance of a baby with 2 embryos, 2 blastocysts being transferred, perhaps might be 5%, now with embryo banking and selectively replacing only those that are genetically chromosomally normal, the baby rate may be as high as 50 or 60%. The second option is egg donation, and that really is a no-brainer. What you're then saying in women that do not produce any eggs or very few eggs and do not wish to go with embryo banking, you're saying that if you get the eggs from a younger woman, from an egg donor, preferably between the ages of 24 and 34, that those eggs are likely to be normal 50% of the time, and therefore the chance of a baby, even without any fancy footwork, without doing CGH testing or embryo genetic testing and selecting, you'll get a baby rate which is about 60% by putting back 2 embryos. Remember, the key here is younger eggs from a younger donor are going to be more competent, and they're going to be more of them, and you'll develop more blastocysts from fertilization of those eggs and development of the embryos than you would in a woman who's got fewer eggs because of diminished reserve, or from an older woman who might have fewer eggs but on top of it will also have poorer quality eggs with a greater percentage being abnormal. And then the final options are to do embryo donation and or to adopt a baby. This would be the alternatives to doing IVF with own eggs conventionally, or using embryo banking versus egg donation. And I'm not going to focus on these two in this conversation today. So let's start with the obvious, using your own eggs. Very quickly, every one of you here is aware that IVF involves the administration of fertility drugs to make the woman's ovarian follicles produce numerous ovaries produce numerous follicles with multiple eggs, so that with a needle passed along the side of the probe, we can enter the ovaries, suck the fluid out, pass it on to the laboratory, and the lab will identify the eggs and will be able to tell whether those are mature eggs or whether they're not mature eggs. This is what a mature egg looks like. Notice it's got a envelopment around it, much like a chicken egg, the shell, or the zona pellucida. And between the shell and the substance of the egg is a little accumulation, a little body here called the first polar body. This contains chromosomes that have been shed from the nucleus in the egg to leave the egg, hopefully, with exactly half the number of chromosomes that it started off with 36 hours before it's ovulated or extracted, after the HCG trigger shot. The HCG trigger that you use, the Novarel, the Profasi, or the Ovidrel, this will cause the eggs, the chromosomes, to enter into a division known as meiosis, where they halve the chromosomes, and the half that are not used are shed and sent out of the egg into this polar body, where they will disintegrate and absorb within a few days. What's left then, or should be left, is 23 chromosomes, because the egg starts off with 46, and you should be left with 23 chromosomes inside the egg. A mature egg will have the polar body present, but even the detection that the egg is mature and the fact that there is a polar body to confirm that it's mature doesn't confirm that there's exactly 23 left inside the egg. In humans, very often too many are shed in the polar body, or too few, and you end up with less left inside the egg or more. Such an egg, as I described earlier, is aneuploid or incompetent, and upon fertilization cannot make an embryo that is normal. And such an embryo will either not attach, or it'll miscarry, or it'll cause a birth defect. So this process that happens after the HCG trigger, 36 hours or so before the eggs are harvested through egg retrieval, as I've demonstrated above, this process, known as meiosis, takes an egg to maturity. Maturity meaning it's shed the polar body. But on top of the egg being mature, it has to have precisely 23 chromosomes left inside. Otherwise, it's incompetent. It cannot propagate an embryo that will have 46 chromosomes. Because remember, the sperm comes along with 23, fertilizes an egg with 23, and now you're left with an embryo that has back to 46 chromosomes that it started with, and when it was an egg before it went through meiosis. And such an embryo is competent, and provided it is transferred to a uterus that is receptive, or rendered receptive if it's not receptive because of anatomical or immunologic reasons, will make a baby about 60 to 70% of the time if it's normal. But because we don't know whether the egg is normal by just looking at it, and we don't know whether the embryo is normal by just looking at it under a microscope, we cannot assume that that embryo will make a baby. And the older the woman gets, especially if the protocols for ovarian stimulation are injudicious or recipe type, one size fits all type, you'll end up with a greater likelihood of the egg being aneuploid and propagating an aneuploid and incompetent embryo that cannot make a healthy baby. This is the sperm. All the DNA of the sperm is in the head. This is the tail. And you need to know that the sperm likewise goes through meiosis, divides in two, and then one sperm that's immature makes two sperm that are mature, and one of those sperm with 23 chromosomes will fertilize an egg that is mature, hopefully with 23 chromosomes, and propagate a viable, chromosomally normal, competent, or euploid embryo that is back to 46 chromosomes, which is a rate-limiting factor in human reproduction. So how do we fertilize? Most of us today do virtually routine ICSI. A lot of programs still do spontaneous fertilization. But there's no evidence that women fertilized with sperm coming from a fertile man through ICSI are more at risk of chromosomal abnormalities in the embryo or abnormalities such as deletions that can result in birth defects or losses of the pregnancy. It is only in cases where there's male infertility that injecting a sperm directly into the egg, like is done here, where the needle is pushed into the egg and the sperm released, where you get this kind of problem if the sperm comes from a man who's infertile. And so it is that many of us today, to assure fertilization, go ahead and grasp the egg with a little caliper here, and then a needle is passed into the egg, as you see here, and the sperm is injected. That's called intracytoplasmic sperm injection, or ICSI. And here's what happens the next day. You got the nucleus of the sperm, the nucleus of the egg together inside that egg, and this is a 2PN, and then those two nuclei fuse and make a single nucleus. When a doctor looks, or an embryologist looks through a microscope and sees these 2PN, he knows the egg has fertilized. But if they've already fused into one, it's not always obviously apparent that this has been a successful fertilization. He may think that it didn't fertilize. So you've got to look early on, say 20, 24, 25 hours after fertilization by ICSI. You've got to look at the egg to see which ones are fertilized and detect this two nuclei, one from the egg and the sperm, present inside that egg to confirm fertilization. The egg then starts to divide, and a good quality egg by day 3 will contain between 5 and 9 cells. If it's less than 5 cells, or it's more than 9 cells, such embryos are less likely to be chromosomally normal. They are not all abnormal, but they are less likely to be, because if there's a slow process of development or too rapid a cleavage or process of dividing, it points towards an irregularity or an abnormality that usually signifies that the embryo is inherently abnormal with chromosomal irregularities. The next stage is the blastocyst stage. Here the embryo's got a vacuole in the middle, collection of fluid, we call it a blastocele, and the cells are pushed to the side. This is the trophectoderm. Those are cells we can biopsy to see if the genetics of the embryo is normal. We can also biopsy a cell from the day 3 embryo, which I personally think is a preferable way to go, and I know there are differences of opinion, but there's less strain or stress on the embryo. It's easier to do, and if it tells you the cell is normal from a day 3 embryo, it's so close to meiosis that it's more likely to indicate that this embryo is normal or abnormal as a consequence of meiosis, and those are the ones that can't self-correct. After this process, after meiosis, the cells keep dividing through a process we call mitosis, where they replicate the same number of chromosomes over and over. And in that situation, you can get abnormalities occurring through mutations, leading to what we call mitotic aneuploidy or mosaicism, which can be autocorrectional. Such an embryo that's abnormal because of mosaicism can very often correct itself, but not one that is abnormal because of meiotic aneuploidy occurring early on. Here is the inner cell mass, ICM, of the blastocyst. This is what makes the baby, the inner cell mass. This trophectoderm makes the membranes and the placenta of the baby. Such an embryo, and this is important, remember this, if an embryo does not get to this stage of development, blastocyst stage of development, it is usually and almost invariably chromosomally abnormal. So embryos that don't make blastocyst, what's the point in putting them in earlier? Who are you kidding anyway? If they don't make blastocyst, they weren't worthy of being used. But that doesn't mean to say that if it makes blastocyst, it is normal. It only means that those that fail to reach blastocyst, those are the ones the ones that are abnormal, and those that do make blastocysts are the ones most likely to be normal. Simply stated, if I have a blastocyst in a woman of 30 years of age, 1 in 2 of those blastocysts are going to be normal. But the same looking blastocyst at 45, only 1 in 20 is going to be normal. So it just shows that because you can't see the chromosomes inside the cells of the embryo or blastocyst, you cannot tell for sure that it is normal versus abnormal. So then we put the embryo into the uterus with a catheter and deliver it into the middle of the uterine cavity, and then approximately 8-9 days later we can do a blood test to see if that embryo has begun to absorb and grow into the wall of the uterine cavity. And if that doubles 2 days later and keeps on doubling every 2 days in the early stage of pregnancy, such an embryo is more likely to propagate a viable pregnancy. Here again, just to show you what I mentioned earlier, as women get older, the birth rate declines with age, primarily as a function of the quality of that woman's eggs when they're ovulated or extracted. In other words, whether those eggs are chromosomally normal or not. And I pointed out to you that age is by far the most important factor in determining normalcy. That is why with age, fertility rate goes down, success rate with IVF goes down, and miscarriage rates go up, because this abnormality chromosomally of the embryo also makes it less likely to remain attached. It's the commonest cause of miscarriages. So in summary, because we cannot influence the quality of the woman's eggs we remove, we've got to focus on ovarian stimulation. We can only protect the eggs by using an individualized approach to ovarian stimulation. What does that mean? That means, number one, you want to use an approach that avoids too much pituitary or administered LH getting to the ovary, because that will cause the ovary to produce excessive amounts of male hormone, primarily testosterone. There must be a little testosterone produced by the ovaries, because that is what is converted by the follicle to estrogen, while it also helps the egg develop. But too much testosterone is harmful to the developing egg, and the result is that the egg will be more likely, after the HCG shot forces it into meiosis, to be abnormal. In fact, the chromosomal irregularities, the aneuploidy rate, is higher because when there is corruption of egg development, and that is brought about by too much testosterone developed in the produced by the ovary. That gets into the fluid of the follicle, compromises the way the egg develops, and now when you stimulate the woman, trigger the woman with HCG, you end up with a higher risk of aneuploidy than the age of the woman alone would otherwise dictate. That's important to understand. We can't reduce the chances of egg abnormality by anything known to man. We can't reduce the chances from that which is expected for that woman's age threshold, but we can avoid making it worse by using the wrong protocols. So what kind of protocols deliver too much LH or LH-like activity? The first is if you use what is called a flare protocol, where you give Lupron after the woman's period begins for the first time. You start it then. The Lupron expunges all the LH out of the pituitary gland of the woman. It hits the ovaries, increases the risk of aneuploidy in the maturing egg. You don't want to do that, especially in older women or women with diminishing ovarian reserve, because they are the ones that are more vulnerable to this change. They're the ones that are going to be more likely to develop aneuploid eggs if you increase the LH. The second thing you want to avoid is using clomiphene or Femara in women who are older or women with diminished ovarian reserve who already have a predilection to overproduce male hormone and testosterone. You don't want to do that because both Clomid and Femara increase the amount of LH produced by the woman's own pituitary. This reaches the ovaries and it compromises egg development. Third, you don't want to use a protocol where you're giving the woman too much fertility drug that contains LH or HCG, because HCG in the fertility drug works like LH. Examples are Menopur. Menopur is a drug that is fine in young women, women with normal ovarian reserve, but used in women that are older, it can make it worse, in my opinion, in that it increases the amount of testosterone produced by the ovary, creates an adverse environment for egg development, and results in a greater risk of egg embryo aneuploidy, and therefore lower success rates and more miscarriages and problems. I avoid using high doses of Menopur. I do use some, but never more than 1 vial or 75 units of Menopur per day. Anything more than that, in my opinion, is bad. The preferable, and then the third thing is when you trigger the woman with HCG to make the eggs go into meiosis, try to use a high enough dosage of HCG, which means you've got to inject with 10,000 units of HCG. You often see women who are highly stimulated, and the doctor considers them to be at risk of developing hyperstimulation syndrome, thinking that by lowering the LH dosage, he can reduce the risk. And that is true, he can, or she can. But the problem is that in reducing the dosage of HCG, you don't saturate all the receptors in the follicle, and you reduce the egg conversion or the orderly meiosis process. You've got to give 10,000 units of HCG, which is Prefasi, Novaral, and Pregnile, or 500 micrograms, not the usual 250, 500 micrograms of Ovidrel, in my opinion. I believe that 250 micrograms is too little. Using a lower dose of HCG will lead to a higher risk of egg immaturity and chromosomal irregularities in the egg. So how is the best way to stimulate women who have diminished ovarian reserve or women who are older? I can tell you right now that the tendency to use mini IVF, where you use Clomid, or natural cycle IVF, does nothing to protect the egg from being corrupted during the process of development. It makes no sense, in my opinion, to use mini IVF in older women who are at risk of too much testosterone, which they're already producing because of age and because of their diminished ovarian reserve. They are already producing too much. You've got to be able to suppress the LH, keep the testosterone low, not just go in there and think to yourself, giving less fertility drugs has a benefit. In fact, in my opinion, it has a major disadvantage in women that are older or women with diminished ovarian reserve. My view is you've got to stimulate the woman adequately, but you've got to first lower the LH, and then you've got to keep the testosterone level at a low level all the way through the stimulation, and finally trigger with HCG, 10,000 units. So how do you do that? First, you put the woman on a birth control pill. That'll automatically lower her LH. You can shorten or lengthen the time on the birth control pill to make her have a period when you need her to. Then you give her Lupron on top of the birth control pill for 2 or 3 days, stop the birth control pill, and continue the Lupron. By giving the Lupron, it will expunge all the LH out of the pituitary. The levels will rise, but by the time the period occurs 4 or 5 days later, it's virtually all gone from the circulation. At that point, in older women and women with diminished reserve, I switch the woman from 10 units of Lupron daily, or the equivalent in Superfact or Buserelin, down to half the dose. Or, preferably still, I will switch from Lupron to an antagonist. Lupron is called an agonist. So I'll switch from the agonist Lupron to an antagonist like Ganirelix or Galutron or Cetrotide. Half the regular dose. You don't need 250 micrograms a day. I'll give 125 micrograms a day. That will block release of LH. The agonist expunges it. It's almost like squeezing a waterlogged sponge, keeping the pituitary being the sponge, keeping your fist clenched by continuing to give the Lupron, and no more fills up in the sponge, and that within the circulation is depleted. Or using an antagonist, which is like taking that sponge, waterlogged, dropping it in a Ziploc bag and closing it. So you're avoiding the release of the LH from the pituitary. That's a good thing to do because Lupron can have a tendency to lower response to stimulation. When you use the antagonist and you switch from the agonist to the antagonist, we call it the agonist-antagonist conversion protocol, then what you're doing is you are getting the same benefit of no LH, but you're not suppressing response. And then you stimulate until the follicles are adequately developed and the estrogen level in the blood indicates such, and then you trigger with HCG, 10,000 units. Now, in some women, you have to stimulate longer because they're severely suppressed. If a woman has an AMH of under 0.5 or an FSH level of over 15 on the basal day 2 to day 4 measurement, you probably would benefit from using estrogen priming. And all that involves is giving a bit of estrogen between the time the period starts, when you continue the Lupron till the period starts, and then you switch to the antagonist, which is the ganirelix or the cetrotide. Now, for a period of 1 week before you start the stimulation, you give the woman estrogen, and you give her a dosage of perhaps 2 to 4 milligrams of estradiol valerate twice a week by injection. And then on the 7th or 8th day after doing this, you then continue the Lupron, continue the estradiol valerate, but now on top of it, stimulate with gonadotropins at a very high dosage. The dosage of gonadotropins isn't what causes problems. It is the effect. If you've got a heavier rock to push down a hill, you've got to push harder. You can't say pushing harder causes problems. Sure, if you push a light rock very vigorously, it'll roll out of control. But a heavier rock needs a bigger and harder push. In the same way, stimulating with a higher dosage of FSH recombinant like Follistim or Gonalef or Puragon will be required in women who have diminished ovarian reserve, and that dosage has to be titrated and increased depending upon that diminution. So that's the way I would go about stimulating the woman. Now, here comes an important point. Once you get to retrieving the eggs and you've done ICSI and the egg is fertilized, what I do for many women with diminished ovarian reserve, which offers them the only alternative to egg donation, is I biopsy the embryo and remove one of the cells. Now, a lot of people are doing biopsies on day 5. That's largely because CGH necessary to adequately test a day 3 embryo reliably through this methodology requires a method called metaphase CGH, not the array CGH that is done later on. You'll notice nobody does array CGH on day 3 embryos anymore because it's unreliable. There's too little DNA in a single cell to allow for reliable array CGH testing. But metaphase CGH can do so. And I like the advantage of testing the embryo closer to the fertilization process so I can be more confident that if there's an abnormality, it stems from meiosis and not through mitosis. Because as I told you, mitotic aneuploidy can reverse. Mosaicism can be reversed, and the mosaic embryo can go on to make a healthy baby, whereas if there's meiotic aneuploidy, that embryo is doomed from the start. So I like to get the test done early on. So I remove the blastomere. That DNA in that blastomere is then frozen. We don't send it off. Listen carefully. We don't send it off. We then allow the embryo to continue to develop to the so-called blastocyst stage here, and then we vitrify the embryo. Vitrification is the ultra-rapid freezing method that allows you to store the embryo in a frozen state safely. Before vitrification, we used to slowly freeze the embryo down. Half of them never made the freeze thaw. They die, and those that did survive had much lower viability than the day they were frozen. But with vitrification, you're freezing the embryo 60,000 times faster. So fast that there's no chance of there being of there being any ice formation inside the cells. And it's that ice formation inside the cells that destroys the embryo and damages it. So with vitrification, there's no time for ice to form. The embryo is not harmed. 95% will survive the freeze thaw, and those that do are believed to survive, to be as viable as the very day they were frozen. In fact, pregnancy rates using vitrified thawed embryos are as good and maybe even better than using their fresh counterparts. So I vitrify the blastocysts. And if the woman has made 6 blastocysts or more, we're fine. But usually they will not. They'll only make 2 or 3, and oftentimes 1 or none. Then what we'll do is skip a month, do it again, and every month stockpile more and more blastocysts till we get to that number 6 or more that we're looking for in the older woman or the woman with diminished ovarian reserve, all the time also stockpiling the biopsied cells, the DNA, for future testing. And then when we reach that magical number, whether it takes 1 cycle, 2 cycles, 3 cycles, or more cycles, depending upon the resilience and the fortitude and the financial ability of the individual and the emotional resilience, we will then either in some cases even go further and go longer. I had a woman with me today who absolutely insists that she wants more than 10 blastocysts vitrified before they get tested. But with embryo banking, what we then do is we send, after we've got all the blastocysts collected and vitrified and stored, we then send the DNA, the biopsied material, away on all of them through all the cycles we biopsied from, and we then wait for the metaphase CGH result. For those people that use array CGH, they do the biopsy on the blastocyst, not on the day 3, and do the same thing. Then they vitrify the embryos, and after you've got enough blastocysts vitrified, you send away the DNA for testing. When you get the results, you cross-reference the result with the embryo of origin. You know which blastocysts were normal, and the normal ones are the viable ones. The ones that are abnormal, you discard. You don't use them because they won't make a baby, or they're going to be lost through early chemical pregnancy or miscarriage, or they're going to cause a defect like Down syndrome. So you don't want to keep those embryos. But now you've got a hold of the best possible embryos. Each such embryo that you vitrified, provided you put it in a uterus that is properly prepared with a receptive lining that's thick enough, there's an absence of polyps or scar tissue in the uterus, and where there's no immunologic impediment relating to activated uterine natural killer cells, you put that in the uterus. Each embryo should give you round about a 60% chance of a pregnancy, certainly more than 50%. And look at the difference. In a woman of 45, a similar looking embryo that was not normal from that woman's eggs would have produced less than a 5% chance of a pregnancy, whereas now it's going to be 60%, regardless of her age. Yes, age still does affect outcome a little bit, because the chromosomal measurement or assessment of an embryo is most of the story, but it's not all of the story. There are epigenetic factors, there are metabolic factors that we can't measure, and some of these are also affected by age. So a normal chromosomal embryo in a woman of 30 is a little more likely to make a baby than at the age of 45 when it's normal. But certainly there's no question that you improve the opportunity of a pregnancy by using genetic CGH testing of the embryo. And in the future there'll be new methods. Full gene sequencing of the embryo may prove to be a better way of testing the chromosomes than CGH. But whatever method you use, the selected chromosomally normal competent embryo is the one you put back. Now, there are a couple of important points. Embryo banking has changed the way IVF can be done in older women. But it is true that it doesn't improve the embryo's quality by testing it. It only helps you identify and select those that are normal. So that means that if you were to have put back the embryos over as many times as it would take to use up all of those that made it to blastocyst, you'd have eventually ended up with the same chance of a baby as you would with CGH. But in the process, you may have had to do numerous attempts. You may have had to take the risk of several-fold increase in miscarriage, and there's a greater risk of birth defects. By doing embryo banking, you can stop the clock long enough to accumulate enough embryos to give even the older woman a reasonable chance of having a baby, where she would not have had that chance unless she went to egg donation. Now, there's a second word of caution. A lot of women who do this are so far advanced in age on the biological clock, and their ovarian quality is so affected, there's so few eggs that they produce, that we go through 3 or 4 or even more cycles of embryo banking and we don't get a single blastocyst that is normal. And women must be cautioned that this is an option, but it doesn't guarantee a good outcome. If we get to blastocysts and we get normal ones, then the chance of a baby is about as good as using an egg donor, a young egg donor's embryos derived from a young egg donor's eggs. But it is not a guarantee that they'll even get to the point of transfer simply because they go to banking. Maybe half the women that go through this, depending upon the distribution of age and how badly their ovarian reserve is, will even get so far as to be able to do an embryo transfer. But for those that feel strongly about using their own eggs, or want to try this at least before they go on to do egg donation, to my way of thinking, if you can emotionally, financially afford it, it is certainly an option and an alternative to using egg donation. So now we come to and I've explained what embryo banking is. We freeze the vitrified embryos that have been biopsied earlier on in the cycle. We stockpile them over several IVF retrieval cycles. The embryos are chromosomally tested once we've got to the end of the process, where there are numerous embryos, and then ultimately we send out all the DNA, all the biopsy material, for one single test that will measure them all, that cuts the cost and allows us to then, when we get the results, know which one of those embryos we're holding are normal, and it will improve pregnancy rates, reduce miscarriage rates, lower the birth defect rate. But again, the caution. The testing itself doesn't make better embryos, so cumulatively you could end up in the same position if you kept doing repeated transfers sequentially until they're all used up. And there are some women that will never get to the point of having normal embryos. I'm touching on egg donation. All of you know what this is. Today we can take eggs from a young donor, fertilize them, replace the embryos into a receptive uterus of a recipient, fresh, or we can freeze them, bank them, and then put them back later. With vitrification of blastocysts, we can now hold the blastocysts of egg donors for as long as we choose, and the woman can come back and have them put back at her convenience. And I say that because many of my patients come from outside the United States or from outside the state, from all over the world. They like to get their donor eggs, they like to get their sperm of their partners sent to us, dispatched to us, eggs harvested from a donor, embryos generated, blastocysts created, and then these are vitrified. And then they come back to have the embryos transferred at their convenience. It's much easier, less disruptive, and highly successful. It doesn't reduce the chance of success. The other way is to get eggs from donors and freeze them for banking. No matter what anybody tells you, using banked eggs that are frozen isn't as successful as using fresh ones. An egg is a single cell. When you freeze a single cell, there's always the risk of damage. The only time banked eggs are as good as if they were from using fresh eggs with egg donation is if you tested the eggs beforehand chromosomally to make sure they CGH normal, by removing that little polar body that I showed you that is extruded from the egg and counting the chromosomes there. And because it's a mirror image of the chromosomes left inside the egg, you then know what the number of chromosomes left in the egg is, and you know which ones are normal. If you use eggs that have been banked and that have been CGH or chromosomally tested in advance, the baby rate per egg that you freeze is 6 to 7 times higher than it will be if you use eggs that are stored in a bank where the eggs have never been tested. I'm not aware that there is any such bank available at the moment in America. We're in the process of working towards developing an egg bank of genetically tested eggs. And when that comes into being, I think it'll be a game changer. Now, you don't need to do chromosomal analyses on the embryos derived from the eggs of a donor because 50% of them are going to be normal anyway. You may as well just put in 2 for the same chance of success. Let me conclude by showing you again, by comparing conventional IVF with IVF done using an egg donor and with staggered IVF, otherwise known as embryo banking, per cycle of transfer. And this is per transfer. Look at what happens in age. You see, as I told you earlier, the baby rate goes down with advancing age. This yellow one here is conventional regular IVF, where age affects the quality of the eggs and reduces the chance of pregnancy while increasing the risk of miscarriage. Now look at the chance of a baby with egg donation. It reduces a little bit with age because age causes certain problems in the uterus that reduces implantation a little bit, but it's well over 60% in women under 35 and easily 50% in a woman above 43. So it's relatively constant. Look how this matches the baby rate when we put back 1 or 2 blastocysts that have been CGH tested for embryo banking. And when we put these back, even one of them at a time, you see that the pregnancy rates are even a little bit higher than they will be with egg donation. So it only goes to show that when you look at the pregnancy rate per embryo transferred, egg donation and staggered IVF, if you get to the point of the transfer, will be equal to one another. When you look at the miscarriage rate, the same thing applies. Miscarriages in the yellow go up with age. Miscarriages with egg donation are higher than they are when you do staggered IVF, which simply means you put the embryo back in a different cycle to the one where you remove the egg. With embryo banking, it stays low throughout, whereas the miscarriage rate with egg donation remains much lower than it is with conventional IVF in comparison to advancing age, but does increase slightly. You can see it going up slightly. That's again because the uterus becomes less hospitable as women get older. Thank you for your attention. I know that was quite long and cumbersome, but I think it opens the door to a lot of discussion. So for those of you that are still with me, I invite you to post your questions and to put them in the column designated, and I'll start answering them one by one as we get to them. I'm just trying to find my way through this. It won't take long. Here we are. So let's start with the first question. The first question says, I am 41 years of age. I just did my first IVF in New York at SRM. I was planning on doing a day 5 frozen PGD embryo banking, but I had 7 eggs, 5 were mature and fertilized with ICSI, but only ended up with 1 blastocyst. That is my point I made earlier on. As you get older, there's less of a chance that the embryo will make it to blastocyst, and much less of a chance that that blastocyst is going to be normal. So this merely stands to confirm and to exemplify what I told you earlier on. You just have to keep on going, because had you put these embryos in earlier, you wouldn't have had a baby anyway. When is it appropriate to do embryo banking? How embryos in the cycle, how many are needed in a 41-year-old? Again, that's an impossible question to answer, because it all depends on your ovarian reserve and how many blastocysts you make. Remember, the goal is to try to get to 6 blastocysts or so. So you take the eggs, you fertilize them, make embryos to blastocysts. How many cycles will be needed on an average for a woman with normal ovarian reserve at 41? Probably about 2 or 3. But at 41 with low ovarian reserve, there's going to be more required. It could be one if the woman that makes lots of eggs and makes 6 blastocysts first time. So it's a work in progress, and you have to take it step by step. Michelle asks, my question is about shared cycles. I'm 45 and will be driving to California to do a shared cycle because no clinic in Vegas does them. Why not? That's a very good question, Michelle. The problem with doing shared cycles is that you don't know how many embryos you're going to end with. And what do you do with the odd number embryo? Who gets that? We have just decided that the emotional impact of one woman getting pregnant and the other not, have the one woman getting blastocysts and the other one not, of getting an additional blastocyst left over and what to do with it, makes it not worth the effort. So we do not, in our program in Las Vegas, do shared cycles. Not that from a pure pragmatic point of view it isn't workable. I just don't need the hassle, and I think it causes more disruption and emotional risk than it need do. Jennifer says, I'm 37 years old. I did 3 IVFs and failed. I have diminished ovarian reserve. I respond poorly to meds and only get 2 good eggs, and 1 fertilizes and gets put back in me and doesn't attach. Is it worth to do another IVF or go straight to donor? I need to know what your ovarian reserve is, and that requires information about your FSH and your AMH. And I need to know exactly what protocol you were put on to know whether you could do better with a judicious protocol. If the answer is that you're using the best protocol, you have a very low AMH, and you have diminished ovarian reserve, and you're only producing 2 eggs, then yes, I would go directly to egg donation. If not, and again, I would be delighted, Jennifer, to go through that with you. Call 800, what is it? 780-7437, 1-800-780-7437, and set up a consultation by Skype so we can look at those things and I can give you advice that you sorely need, because I think you need to make that decision. Do you do egg donation directly or do you go to embryo banking? Laurie writes, I'm 32, I have an FSH of 17 and AOH of less than 0.1. I have not tried IVF because I have only ever gotten 1 follicle. Laurie, you need an egg donor. Don't even waste your time with embryo banking, because with those parameters, you certainly have got such depleted reserve that menopause is imminent and the chance of success with your own eggs is minuscule. Christina writes, after a cycle is over, how do you evaluate the success of the stimulation protocol? If you've done CGH testing, obviously the ultimate success is you get pregnant and have a baby. But if you don't get pregnant and you want to know whether the stimulation was appropriate, you look at the number of eggs, the number of embryos, the number of blastocysts, and if you did genetic CGH testing, how many of those were normal? You know what the normal rate should be in a given age, and based on that you can know whether it was the appropriate way to go. Jennifer writes, I was also told to do IVIG because of an implanting issue. I'll come back to that in a moment. I'm sorry I skipped one. But let me answer that question that I was at. Can you go back to the IVIG question? Okay, IVIG is used. Jennifer, you asked another question first, sorry. You said I'm 37 years old and did 3 IVFs and all failed. I have diminished ovarian reserve. I didn't respond. I respond poorly to medications and only get 2 good eggs, and 1 fertilized and gets put back in me. It doesn't attach. Is it worth going on? I think I answered that question. And I indicated to you that you need to be evaluated to see what your reserve is really like and whether the protocol you used was appropriate. The use of IVIG is not necessary anymore in this day and age. We don't use IVIG. I was one of the strongest proponents of IVIG because it does work. But it also costs $3,500 to $4,000 a pop. And you may need more than one of those per cycle. And it's no more effective than using intralipid. Remember, both IVIG and intralipid are only indicated if you've got activated uterine natural killer cells, as indicated by a K562 target cell test done in your blood, or by a cytokine analysis after uterine testing. So using IVIG is no longer needed. Intralipid, instead of $3,500, costs $150. And it is just as effective, provided it's used in cases with activated natural killer cells and in conjunction with steroid therapy such as dexamethasone or prednisone. Teresa says her clinic discounts natural killer cells and IVIG or intralipids as highly experimental. Teresa, in my opinion, there are none as blind as those who will not see. There are thousands of women that have had babies through this treatment. There's nothing in IVF that has stood the gold standard test of absolute scrutiny. In my opinion, it's usually doctors that do not want to try and understand or have an open mind or have an axe to grind that don't use IVIG. I'm actually quite tired of that kind of approach, but unfortunately there's nothing that I can do to change attitudes other than those of patients who come here when they're not being treated and need IVIG and get pregnant at SIRM very often. Can you produce many eggs with a very high MH but not PCOS and yet have poor egg quality? The problem with high ovarian reserve is that the woman often hyperstimulates. The doctor, being fearful that she will end up in the hospital with serious life-endangering complications, decides to trigger with HCG before the eggs are fully developed to avoid the estrogen level going too high and putting her at risk. The problem with that approach is that the eggs aren't ready any more than taking a plum off a tree before it's developed properly to be put in the window shelf to ripen, so these eggs need more time. And the only way you get more time is by doing something called coasting, prolonged coasting. Go to my blog, ivfauthority.com, type in ovarian hyperstimulation syndrome and prolonged coasting and read up about it. If you do that, you do it properly, timing being everything, you will be able to get good eggs. Those eggs will have a better chance of making good embryos. The other thing that is often done in such cases is the doctor will trigger the woman with Lupron or will use a half dose of HCG when she really needs a full dose. Unfortunately, in my opinion, while that does protect the woman from the risks of ovarian hyperstimulation syndrome, it does nothing to protect the eggs from their otherwise likelihood of not developing properly, going through meiosis irregularly, and ending up being chromosomally abnormal. Where's the next one? Christina writes, while with embryo banking, do you feel that the older the donor, that all older diminished ovarian reserve women, I'm 41, she says, should do PGD testing? I can't seem to get enough blastocysts to test. How many blasts do you feel should you collect before testing? Again, you've got to keep going until you've got at least 6, in my opinion. In some cases you need more, and one of those examples I don't have time to discuss here are women where the embryos, even if they're normal, will have half the chance of making a baby that they otherwise would if they went into a woman who didn't have the problem. And the problem I'm referring to is a rare form of immunologic implantation dysfunction where there's DQ alpha matching that is partial. In those cases, each embryo is going to have half the chance, even if it's CGH normal, of being the one that will attach, because 1 in 2 embryos are abnormal and wouldn't attach anyway. 1 in 2 embryos will be immunologically clashing with the uterus and wouldn't take anyway. But this is not the time to go into detail here. In that event, you need more than 6 blastocysts to freeze. But doing blastocysts on day 5 or 6, freezing those and stopping when you get to 6 is, I think, the way to go. You said, and this is Carrie, says she's 37, her FSH is 10. She has a unicornuate uterus. That means it's only one side with one tube and half its normal volume and dimension. She's had 3 miscarriages and 1 ectopic. only one tube is connected, and we know that from what I've just said. She's done one IVF with a day 3 transfer into a gestational carrier who miscarried at 6 weeks. And she says, my 2 remaining embryos did not make it to blastocyst. The obvious reason they never made it to blastocyst is because they were abnormal. Chromosomally abnormal. I don't even think you need to use a surrogate. A unicornuate uterus, if properly treated and managed, can carry one baby with one embryo. And here's another indication why CGH testing is advisable, because you only want to put back a single embryo, and it's far better to put one back that has been tested and found to be normal for a much higher pregnancy rate. But you need to be sure that the embryo you're putting back is chromosomally normal, and that's where I believe CGH testing is very helpful as well, whether the embryo goes into your uterus or into a surrogate's. Annette says, if I had good frozen eggs, how can I tell the reason it's not taking is my uterus or the eggs? If the eggs are chromosomally normal and they make embryos that are chromosomally normal, they should attach with more than one embryo being transferred over time. If they don't, by a process of elimination, if it's not the seed, the embryo, it's got to be the soil, the uterine lining. And it could be the uterus having too thin a uterine lining, or it could be that there's scarring or polyps or fibroids sticking into the uterine cavity, or it could be that there's an immunologic cause. And these things need to be carefully evaluated. Annette, if you have an interest, call 1-800-780-7437, set up a free Skype examination with me, and we can discuss your case in greater detail. Oh, sorry, it's not a free consultation. I'm just reminded. They're not free, but they are not expensive. Each one of these consultations is about $150. And now Lena says, what is the level of the LH that you ideally like to see during stimulation? If you use the protocol I've recommended, namely using the Lupron and the agonist-antagonist approach, or the long pituitary downregulation protocol, you don't need to measure LH because it will always be low enough. If, on the other hand, you want to measure it, I'd like it to be under 2. Marty writes, if the man is infertile, how would you then fertilize the egg if not by ICSI? You'd use ICSI. That's all there is. I've got another question here which says, is it definitely necessary to skip a month when embryo banking? What happens if you go back to back? You need your ovaries to get a rest, because when you extract fluid out of a follicle, it fills up with fluid, with plasma, and it forms a theca-lutein cyst, or theca-luteinized follicle, which can last for several weeks. And if it's present in the ovary, it's my belief that the ovary will be less likely to produce normal, healthy eggs. And so my feeling is give the ovary a rest for one cycle between each. If the woman produces very few follicles and very few eggs, then you could perhaps go back to back. But in most cases, it's a good idea to rest one cycle between each. What is your opinion about acupuncture? I think acupuncture improves blood flow through the ovaries, but not through the uterus. Therefore, I think it may have a role and a benefit being done immediately before or immediately after embryo transfer. But it is not of value throughout the cycle. In my opinion, it's a waste. I missed one, right? Which one did I miss? Is embryo adoption a viable option for couples with DQ alpha partial matching? Absolutely it is. Absolutely. Provided, of course, that the male who produced the embryo doesn't match with the woman who's going to receive the adopted embryo. The chance of that happening is less than 10%. And of course, provided, of course, if the woman has got natural killer cell activation, that is dealt with intralipid in advance. The other one says, as for PGD testing, I always was under the impression that day 5 testing is 90% accurate, day 3 only 66%. That is, in my opinion, a fallacy. In the old days when they used array CGH on day 3 embryos, that may have been the case because it's not that reliable. But if you do metaphase CGH as we do on day 3, I believe it's more reliable than doing a raised CGH on day 5. Let me say categorically, if an embryo is normal on day 5 through a raised CGH testing, and it's normal on metaphase day 3, they're just as reliable as one another. Problem is when an embryo is abnormal with a raised CGH and the blastocyst, in my opinion, it's more likely to be due to mosaicism, and therefore something that might not necessarily have required that that embryo be discarded. I would like to understand why this protocol isn't more accepted by other doctors. In fact, this they consider this to be far out due to lack of sufficient studies. I didn't want to do this, but you're forcing my hand. There isn't a single thing we do in IVF clinically that can stand the test of gold standards testing. That's referred to as randomized controlled studies. When you separate a group where all the factors that can affect outcome have been removed, have been eliminated from playing a role, except the one you're measuring. And you cannot eliminate all those factors if you don't know the embryo is normal. Because 80% of failures in IVF and 80% of miscarriages are due to abnormal embryos. In the old days and until quite recently and even today, most studies do not first start with the preconception or with the requirement that the embryo be CGH or chromosomally normal before you use it. If you don't even know if the embryo is normal and then you're evaluating by splitting into two into a randomized fashion into two groups and to try to identify whether some other variable is affecting outcome, how can you possibly have a reliable result? So all of the studies that have been reported, whether it be ICSI, TESI, GIFT versus IVF, the type of protocols we use for stimulation versus what others use, whether you do assisted hatching or you don't, whether you do co-culturing or you don't, whether you do uterine scratching or you don't, none of them have been tested in an environment where you know that the embryo you're putting back is chromosomally normal, and therefore they're not worth the paper they're written on. You need enormous numbers to be reliable in that setting, in my opinion. But bottom line, if you were to write a textbook on those studies that can stand the test of gold standard testing, where you know that you've eliminated all of the interfering variables so that only the one that you are trying to evaluate is randomized and you can do it reliably, is based, it would be less than a page long. You've got to know the embryo is normal before you do any studies that look at outcome as the end point. Can you go over the IVF protocols recommended again? Unfortunately, Jenna, I cannot. You can go into my blog and read up on that on ivfauthority.com, or you can set up a Skype consultation with me by calling 800-780-7437. Yehudith writes, I'm 42, I've diminished ovarian reserve, AMH is 24, FSH I don't know, 2 failed IVFs, microflare cycles with 5 eggs, 3 fertilized, didn't make it past day 3, obviously meaning, of course, that they were chromosomally abnormal. The antagonist protocol, she got 9 eggs, 5 fertilized, 2 made it to day 5. Please remember what I said earlier on. The microflare protocol is one where Lupron is given after the period begins. It surges LH into the circulation, and that causes increased ovarian testosterone. This explains why in your first cycle so few eggs and none of them were normal because they didn't make it a blastocyst. Whereas in the one with antagonist, you were more likely to end up with embryos that made it a blastocyst. This explains exactly what I've just said, and I rest my case. Notably, your AMH of 24 means that you had the test done outside the United States. Probably they measured it in picomoles per liter rather than nanograms per milliliter. But based upon your response, you have diminished ovarian reserve. Then RZ says, I'm 35 and I have 2 kids, 11 and 8, trying to get pregnant for a while with no luck. newly found that I have a thickening and polypsin in the uterus caused by hormonal imbalance. I did a DNC and found normal cells. What are the chances the embryo will be implanted? I'm not a believer in polypsin being a factor, so I can answer your question. I don't think it matters, because during the cycle of stimulation, you're taking over the cycle. And if you do banking, you are doing an artificial stimulation with estrogen and progesterone. So I don't think it's a factor, in my opinion. Sadia says, I'm nearly 41 with an AMH of 1.2 and an FSH of 7. The FSH is obviously not reliable here. I'd love to know what your estradiol was. It was probably greater than 70 when they measured your FSH, because an elevated estradiol will falsely suppress the FSH, but not the AMH. You said you've tried IVF once, had 8 eggs retrieved, 6 fertilized. You had a day 3 transfer, 4 embryos, didn't work. You were put on birth control pill for a month, and off and on, and the month prior to and also the month prior to stimulation. Then you were stimulated with Menopur and Follistim. In my opinion, Sada, you heard me mention the agonist-antagonist conversion protocol. That is the one I would definitely use in your case. I don't think giving you 150 units of Menopur, in my opinion, is as low as it could be. I would lower that dose of Menopur. I would use a different approach, probably to stimulation completely, and maybe we should talk. Call the 800-780-7437 number, toll free, and set up through Tina a consultation to discuss with me the options before you. Especially in your case, embryo banking seems to be one that is probably ideal for you. Christina writes, do you recommend embryo banking in younger women with partial DQ alpha match? We did our first one and had 3 metaphase CGH normal blastocysts. The first FET failed. Obviously, the embryo put back was a matching embryo. I think it's a good idea to get more embryos available, but you are young, and if your ovarian reserve is normal, you can have these embryos put back and then start again. Otherwise, yes, you could bank more, but that would only be more imperative if you were older. What is the best supplement to improve egg quality in the 4-month period before recruitment process completes? There is no known medication that will improve things. There is no known method. Don't fool yourself, and I would not use DHEA only because it converts to testosterone in the ovary. And if you already have diminished ovarian reserve, the last thing you need is additional ovarian testosterone. For that reason, I would avoid DHEA. And if you stop it, within a month or 2, you're back to where you were before you started, and you're fine. But again, supplements, the only ones that we know do have benefit is folic acid, probably coenzyme Q10, and perhaps omega-3s such as fish oil, 2,000 milligrams a day. But even there's no proof that it really benefits. It doesn't do harm, as DHEA, in my opinion, might do. So I strongly recommend that you forget about the idea of supplements, because none of them are going to change bad eggs to good eggs. I am having a donor embryo FET. Can you please let me know what the treatment you advise for adenomyosis? Adenomyosis, if the lining is adequate and you don't have activated uterine natural killer cells, should not affect your implantation. There's nothing particular that you need to do. You need to have a lining, ideally of over 9 millimeters, but over 8 would also be adequate. What might cause my AMH to go from 2.6 to 0.9 in 1 year? Rapidly diminishing ovarian reserve, and it clearly exemplifies what I've said, and that is that ovarian reserve can drop like a brick really fast, and so older women should not allow the grass to grow under their feet. Women who've already got diminishing ovarian reserve should be proactive and move quickly and make hay while the sun shines. What do you think of the EMBRYOscope, time-lapse embryo incubator to determine if the cells are normal based upon cell division rates at certain times. Honestly, I don't know a lot about it. I don't think there's a lot of evidence that it does help. Embryoscopy was really developed for the purpose of evaluating the embryo after it's attached into the uterine cavity, to see, to remove it selectively without having to scrape out the entire uterine cavity. So embryoscopy has a role, but it's not, in my opinion, a great role, and it's not, in my opinion, a real benefit. What's the estimated cost for a baby's sex selection by IVF? It's probably the cost of a regular IVF cycle, plus genetic testing of about $3,500. And you know as well as I do that the cost of IVF varies from center to center and location to location. Do you think all women past age 40 need CGH PGD testing? This is my opinion. I do believe that it is wise because time's running out, but it's not essential. If you've already got a child, and having another baby would be nice but not critical, you can keep doing IVF until you have a baby. But if this is your first child and time's running out, you've got to make hay while the sun shines. And so I think embryo banking with staggered IVF is a way to go in women over the age of 39 years, or women that are younger who have diminished ovarian reserve. Does SRM use the embryoscope? I don't, but we used to use it in St. Louis. It was more of a research tool than of real clinical value, in my opinion. It says, oh, thank you for the kind words, Christina. It's always a pleasure for me to do this anyway. Danisha says, I'm 26 years old. I have diminished ovarian reserve. I've done one IVF, got 9 eggs, 8 blastocysts, 2 were placed. I got pregnant and had a miscarriage. After my 4th beta test, I was recently tested for NK cells, and they tested normal. I have 6 frozen embryos, Danisha. Please differentiate between testing for NK cells and the proper testing for NK cells. I'm not suggesting it was wrongly tested, but it may have been. The concentration of NK cells in your uterus is irrelevant. The more the merrier. They're good guys. They help implantation. The problem comes when they are releasing toxins called Th1 cytokines that attack the roots of the embryo if they're in excess and damage it and destroy it. You've got to be tested using a blood test known as the K562, target cell test, or uterine cytokine analysis. Measuring the amount of cytokines in your blood is irrelevant, and I strongly suspect that you might very well have activated natural killer cells. Get them tested properly, or call me and let's talk via Skype. Again, 1-800-780-7437. 1-800-780-7437. It sounds like you might not support a PrEP cycle of birth control pills with testosterone prior to antagonist cycle. Absolutely not. For all the reasons I gave you, I would absolutely decry using additional testosterone in the same way as I think using DHEA, which causes the ovary to produce too much testosterone, is harmful to the egg. Amber says, I asked the question about adenomyosis. I do have uterine natural killer cells, and I'm wondering in this case, what would your treatment be prior to FET? If you've got truly activated natural killer cells by the K562 target cell test, I would infuse 100 cc's of 20% intralipid dissolved in 500 milliliters of normal saline into the uterus 10 days before the embryo transfer, and I would repeat it if the beta HCG test becomes positive. I would add to that probably 0.75 milligrams of dexamethasone, the steroid, daily orally, starting at the same time as initiating the intralipid and ending on the 10th week of pregnancy, or earlier should the pregnancy test become negative. I'm 42, had an FSH of 6.6. What I don't know what this is. TSP, I don't know what that is.
TSH.
TSH of 1.86, thank you. and prolactin of 13. What do you think of these stats? It could be PCOS, but there's a lot more you need to do to make the diagnosis. You need to have her blood tested for on the 2nd to the 4th day of the period for FSH, LH, testosterone, AMH, DHEAS, dihydroepiandrosterone sulfate, androstenedione, 17-hydroxyprogesterone, and for blood insulin levels. That'll help determine whether she's got PCOS and what the type of PCOS is that she does have. Oh, we lost that. Come. Where are we now? What we no. Go back to the questions. All right, Steve. It was my pleasure. I hope that was helpful to you. It's a lot of information. The number again, 1-800-780-7437. Up on this on the video now. Amber says, so you administer intralipids into in the uterus? No, intravenously into the veins. 7 days prior to embryo transfer is probably a little late. Ideally 10 to 14 days before embryo transfer. And then, Amber, it depends on what type of immune problem you got. Is it autoimmune or alloimmune? And again, we would need to discuss this by your going to that number on the board, 1-800-780-7437. Ask Tina to set you up with a Skype consultation with me. It only costs about $150, which is less than the average first consultation costs in most settings. I'm doing it because I really want to encourage people to get the information. Okay, that closes it for today. And firstly, let me thank every one of you for attending. We had an enormous... There was one more question. Steve asked, is this presentation recorded and can we access it?
Right back to the same link.
You go back to the same link anytime as of tomorrow, and you'll find it there. It will always be available on our website. It's my pleasure to have done this. I enjoy it very much indeed. We had over 100 people sign up for this particular webinar, and it was very rewarding to do it. It's a complex issue. It's one that affects a large and growing proportion and population of women seeking IVF. See it in its proper context. Embryo banking is an alternative to egg donation. It is no better. It's as good if you get to the embryo transfer. Not all women will get there, and not all embryos that are normal will take. So you need to know there is a risk, but it is an excellent alternative for women that don't want to use donor eggs. It comes at a cost financially and emotionally, unfortunately, like anything else. So thank you all very much, and I look forward to hearing from you in the days and weeks ahead. We'll have another webinar. We'll think of a topic and come up with another one in about 6 weeks, so please stay posted for that. Have a wonderful evening, folks.